So osmolarity, before going on to the osmolarity proper, let's see what is mole. The mole is called as a gram molecular weight of a substance. For example, oxygen has an atomic number of 16. So oxygen molecule will have the molecular number of 32. So the molecular weight is equal to 32. The gram molecular weight, that is 32 gram, is equal to 1 mole. So mole is nothing but gram molecular weight of a substance. Now going on to the osmoles, the number of freely moving particles are called as osmoles. Always 1 mole of oxygen molecules will give 1 freely moving oxygen molecule. So the osmolarity will be 1. The osmole is 1 osmole, and whereas a sodium chloride will give 2 freely moving particles. So it is having 2 osmole because sodium chloride will split into sodium and chloride. Potassium chloride will have 2 osmoles, and the albumin will have 1 osmoles because it doesn't split. Carbohydrate, glucose will have 1 osmole. 1 mole of oxygen will have 1 osmole, 1 mole of sodium chloride will have 2 osmole, 1 mole of potassium chloride will have 2 osmole, 1 mole of albumin will have 1 osmole, 1 mole of glucose will have 1 osmole. So this shows that the number of freely moving particles it gives rise to osmoles. Now, two important, before going to the two important terms, let's know what is concentration. Concentration is the amount of solution divided by the volume of the solution. The amount of solute divided by the volume of the solution. Solute divided by volume gives the concentration. The solute is measured in grams and divided by volume gives the concentration. Now going on to the two terms, osmolarity and osmolality. Only thing here differ is number of osmoles per liter of solution is called osmolarity. Number of osmoles per kg of solution is called as osmolality. The kg will not change with the temperature, and this will not be altered by the presence of other solutes, whereas liter will alter with the temperature. The temperature will alter the volume, and also it will be affected by the other solute in the solution. Other solutes in the solution will alter this osmolarity value. So osmolarity is nothing but number of osmoles per liter of solution. Osmolarity is nothing but number of osmoles per kg of solution. Now this is the osmolarity and osmolality, the two differences we need to know. So the blood osmolarity is 280 to 290 milliosmoles. The blood osmolarity we measure in milliosmoles, so it is 280 to 290 milliosmoles. So let's know about something about osmotic pressure. Now here we have taken two compartments, compartment 1 and compartment 2, which has been separated with the help of a semi-permeable membrane in the middle, which is permeable to water, but it is not permeable to solutes. It is permeable to water, but it is not permeable to solutes. Now here we have two chambers, the chamber 1 and chamber 2. In the chamber 1, the number of particles are much less compared to that of the chamber 2. The chamber 2 has much higher particle than the chamber 1. Now what happens when, because of this, the osmolarity on the chamber 2 is very high compared to the osmolarity in the chamber 1. Because of osmotic pressure, the water starts moving from the chamber 1 to chamber 2, and there will be some change in the level of water in the two chamber. Now this change in the level of water in two chamber is because of certain pressure exerted on this on by this chamber 2, which is responsible for the pulling of the water from the other side, and this pressure is called as the osmotic pressure. This pressure is called as the osmotic pressure. And now, how to calculate the osmotic pressure based on the osmoles that we know, based on the osmotic osmolarity that we know, how to calculate the osmotic pressure. Now we have one equation which says that 1 milliosmoles is equal to 19.3 millimeter of mercury. As I have already told, the blood osmolarity is about 280 to 290 milliosmoles. So if 1 milliosmole is 19.3, then the blood osmolarity will be 57 millimeter of mercury, because of the 280 to 290 osmoles will produce a pressure of 5597 millimeter of mercury. So this is the osmotic pressure exerted by the blood. Now first thing to know is osmolarity of the blood is 280 to 290, but it is always 290 is the better answer. The 290 is the specific answer. If you want, that will be the 290. Now 290 is the osmolarity, but the pressure exerted is a 5597 millimeter of mercury. Now out of this, the maximum concentration for this osmolarity or for this osmotic pressure is because of the sodium, always sodium and its associates. So we always write 2 into sodium plus 0.055 glucose plus 0.36 BUN. So the maximum concentration is always by sodium. Out of 280 to 290, up to 270 osmoles is because of the sodium and its associates, and up to 5 milliosmoles it is by the glucose, up to 5 milliosmoles it is the blood urea nitrogen. So maximum concentration is by the sodium and its associates, then it is the glucose, then it is the blood urea nitrogen. Now out of 290 milliosmoles, we have told that 270 is by the sodium, plus 5 is by the glucose, plus 5 is by the blood urea nitrogen, plus 2 will be by the protein. So protein has very less osmolarity because it is having high molecular weight. Because it is having high molecular weight, it is having high concentration, but freely moving particle in this will be very less. It will be having low freely moving particle. It will be low freely moving particle, because each particle is very heavy. So it will be, its molecular weight is in 69,000 and 70,000, in that range. So it is having very high uh, the molecular weight is very high, which will lead to high concentration, but it is having very less freely moving particle, because of which it is having low osmotic pressure. Up to 2 is the osmolarity which is contributed by the proteins. Now 2 is the osmolarity contributed by the proteins, and it exerts a pressure up to about 30 millimeter of mercury. Out of 5597 millimeter of mercury, the contribution from the protein will be only 5597 millimeter of mercury. Now so which protein, out of proteins, which protein is contributing the maximum? That will be the albumin. Albumin is the one which is contributing maximum for the protein, which is the for the osmolarity exerted by the protein concentration in the blood. The protein concentration in the blood is about 6 to 8 gram per deciliter, out of which albumin is the one which is having maximum contribution. 3.5 to 5 gram per deciliter is by the albumin. Though its concentration looks very high, the contribution of this for the osmolarity is very low. Now let's see. We know that the sodium is the one which is contributing maximum for the osmolarity. Now let's see what happens when there is change in the sodium concentration. Now let's suppose that is the sodium has increased, the sodium concentration in the blood has increased. It will lead to very high osmolarity in the blood. Whenever there is very high osmolarity in the blood, it tends to suck the fluid from outer spaces so that the osmolarity reduces, and this osmotic pressure is responsible for the pulling of water from outside. So whenever there is sudden hypernatremia, increase in the sodium, it will lead to shrinking of the internal cells. The internal cells start shrinking. All the cells will be start shrinking because they lose all their fluid which will go into the blood because of the hypernatremia. To prevent this, what the body does is it will send all the sodium from the blood vessel into the cells, and along with this it will also produce some osmotically active substance like betaine, inositol and glutamine within the cells. So this all will increase the osmotic pressure of even the intracellular space. So extracellular space already has increase in the osmolarity in the extracellular space because of the hypernatremia, and now even the intracellular space will also lead to increase in the osmolarity because of movement of sodium inside, as well as because of the production of betaine, inositol and glutamine. Now this takes a certain amount of time to happen for betaine, inositol and glutamine to be produced. It takes certain amount of time. So if this happens only in case of chronic hypernatremia, that is when there is the hypernatremia by beyond the 24 hours, then these changes will be occurring. Now the balance of the osmolarity is maintained between the intracellular fluid as well as the extracellular fluid. So there is no movement of fluid across the cell membrane or across different spaces like intracellular space, extracellular space. There is no movement of water. But now, looking at the hypernatremia in the blood, if we try to correct this hypernatremia rapidly by giving half normal saline, or half normal saline normally we give, then this will lead to sudden increase in the water content in the blood, and there will be sudden decrease in the osmolarity of the blood vessels. This will lead to pushing of this water into the intracellular space because intracellular osmolarity is very high now. Because of the movement of water from the blood vessel into the intracellular space, because of the betaine, inositol, glutamine and the sodium which has entered has maintained high osmolarity inside the cell, the water start moving from the blood vessel into the intracellular space, leading to the edema of these cells. So this will lead to the edema of these cells. So this is why we say if the hypernatremia has occurred more than 24 hours by a pathologist which is contributing for more than 24 hours, then even the correction should be done slowly. If a fast correction is attempted, it will lead to cerebral edema. Same way, if a hyponatremia has occurred by more than 24 hours, again these adapting physiology will work there. So even there, we shouldn't do a fast correction. If you do a fast correction, all the cells start shrinking and there will be cerebral pontine myelinolysis. Cerebral pontine myelinolysis. This is why myelinolysis. This is why we shouldn't do a fast correction in a hyponatremia or a hypernatremia if it has occurred by a slower course. If in case hypernatremia or hyponatremia has occurred suddenly, then the patient will always present with the symptoms. Patient will always present with some cerebral neurological symptoms because of the cerebral edema or the shrinkage, because of the sudden change in the osmolarity. Body cannot hold the sudden change in the osmolarity. Now, increase in the plasma osmolarity will be normally controlled by the body by two mechanisms. When the increase in the osmolarity is not very high, if the increase is only about 5 milliosmoles, then the the pers- the patient will not be noticing the change, will not be knowing the change in the osmolarity, but the patient will be subconsciously stimulated in the supraoptic nucleus, which will be responsible for the secretion of ADH, and this ADH will go to the kidney and causes absorption of only the water, not the sodium. So this will lead to only water absorption. So this water comes into the blood and dilutes the sodium in the blood. It will thus decreasing the osmolarity. It's one mechanism. Up to 5 milliosmoles, there is no problem. If the osmolarity has reached up to 300, we told 290 is normal. If it has reached about 300, that is the change is up to 10 milliosmoles, then this will lead to stimulation of the patient, and patient feels thirsty now and he starts drinking water because of the thirsty. So because of this, patients are drinking water. Now the normal osmolarity will be maintained. So these are the two mechanisms by which the patient or any person will be maintaining his plasma osmolarity. Now there are two concepts. One is effective osmoles, and the other one is ineffective osmoles. We okay, this is not sucrose. Okay. There are two concepts. One is effective osmoles and one is ineffective osmoles. The effective osmoles are the substances which when we inject into the blood vessel, it just remains in the extracellular fluid. It just remains in the extracellular fluid, which leads to increase in the osmolarity of the extracellular fluid. It can pull the fluid out of intracellular space, and thus this, if you give these effective osmoles, there will be the suction of the fluid out of these patients, and this will lead to the reduction in the edema in these patients. Whereas the ineffective osmoles, the substances like glucose, urea, and alcohol, these are the substances which are uh, alcohol. These are the substances which are called as ineffective osmoles. These will distribute themselves intracellular fluid as well as extracellular fluid. So if we give these substances, it doesn't cause any change in the fluid level between the intracellular and extracellular fluid. It will increase in both the spaces, how much we have given. Other than that, it doesn't have any effect. But if you give an effective osmoles, it remains in the extracellular fluid and pulls the fluid out of the intracellular space and lead to the reduction in the edema in the intracellular fluid space. Now the effective osmoles include the protein, sodium, protein, inulin, mannitol, sucrose. So these are the substances which are responsible for the effective osmoles. These are the substances which are responsible for